Episode 20 Proximal Control Vascular Surgery Exam Prep. Continue on abdominal aortic aneurysm, iliac aneurysm, including complex AAA and inflammatory AAAs. FRCS and European Board Vascular Surgery Exam Focused Teaching. Welcome back to Proximal Control. I'm your host, Momia. This is the podcast where we prepare for the vascular surgery exams the same way we practice as a day one consultant, with structure, judgment, and control. Because in vascular surgery, control is everything. Alright, welcome back to Proximal Control. This episode is the continuation on abdominal aortic and iliac aneurysm, including complex AAA as well as inflammatory AAAs. I'll keep it structured and exam focused. Let's start with deep dive into abdominal compartment syndrome after emergency AAA repair, as a continuation of our previous episode. A dangerous complication after ruptured AAA repair is intra-abdominal hypertension progressing to abdominal compartment syndrome. The World Society of the Abdominal Compartment Syndrome classifies intra-abdominal hypertension into 4 grades based on intra-abdominal pressure, and this directly drives your management decision. As you know, intra-abdominal pressure normally should be below 12 mm. If it is 12 mm to 15 mm, then you call it hypertension grade 1, that is intra-abdominal hypertension grade 1, 12 to 15 mm. This is the lowest level of intra-abdominal hypertension, and medical management is initiated. No organ dysfunction is expected yet, but monitor closely every 4 hours. Grade 2 is 16 to 20, and this still is intra-abdominal hypertension, but escalating and intensify medical management. Still no indication for decompression unless organ dysfunction is developing alongside this. Grade 3 is intra-abdominal pressure between 21 to 25 mm mercury. This is critical territory. If intra-abdominal pressure exceeds 20 mm mercury with new organ dysfunction, as we have already discussed, that is definition of abdominal compartment syndrome, and that warrants decompressive laparotomy. And this is if medical measures fail, you go for decompressive laparotomy urgently. Grade 4 is the intra-abdominal pressure more than 25 mm mercury, and that frank abdominal compartment syndrome with imminent catastrophic organ failure, and that is immediate decompression by midline laparotomy is the treatment. The key threshold in the ESVS algorithm is if intra-abdominal pressure goes over 30 mm mercury, at any point move straight to intensified medical treatment and prepare for decompression laparotomy. The algorithm is not purely sequential. Intra-abdominal pressure more than 30 can fast-track you to laparotomy even without waiting for further deterioration. Now let's talk about the medical treatment. What do you mean by the medical treatment? As we said, in grade 1, grade 2, you do the medical management. How would you do it? So there are 4 pillars if you want to consider the medical management. The first, you think about improving abdominal wall compliance, and that you can do by epidural analgesia or neuromuscular blockade. Neuromuscular blockade alone can reduce intra-abdominal pressure by up to 50%. You always avoid morphine in this context. Second pillar is evacuate intraluminal content, and that can also help reducing intra-abdominal pressure. How would you do that? By nasogastric decompression. And if there is option, you can consider paracentesis to reduce some fluid as well. Then you can correct the positive fluid balance, and how you do that? Avoid over-resuscitation and crystalloids. Use whole blood and colloids instead, such as 20% albumin. You can also consider diuretics such as furosemide, and if needed, renal replacement therapy, and this will all correct the positive fluid balance. The final thing you can consider is the organ support, that is the optimized ventilation with positive end expiratory pressure, vasopressors to keep the abdominal perfusion pressure higher than 60 mm mercury. As you know, abdominal perfusion pressure is the MAP minus IAP, that is the intra-abdominal pressure. So MAP minus intra-abdominal pressure is the abdominal perfusion pressure, and that needs to be more than 60 mm mercury. Once abdominal compartment syndrome is confirmed, decompressive midline laparotomy is mandate. Then for open abdomen management, you go for vacuum-assisted wound closure with mesh-mediated fascial traction, and this achieves highest delayed primary fascial closure rate and minimize the risk of ventral hernia, intestinal fistula, and graft infection. Now, another deep dive into the colonic ischemia after AAA repair. Now let's move detail into the second major complications, and this is colonic ischemia after AAA repair, especially after repair of a ruptured abdominal aortic aneurysm. Colonic ischemia after AAA repair is classified into 3 grades based on depth of bowel wall involvement. The grade 1 is mucosal ischemia only. This is reversible. The mucosa is ischemic, but the muscularis is intact. The sigmoidoscopy shows mucosal edema, petechiae, or patchy erythema. This is the most common form and usually resolves with conservative management. Then it comes grade 2. Grade 2 is the mural ischemia. Involved mucosa and muscularis, but not full thickness. It is still reversible with appropriate treatment, but carries higher risk of progression. Treated conservatively with close monitoring and a repeat sigmoidoscopy. Then it comes the final grade, the grade 3. That's the transmural ischemia. That is full thickness bowel wall necrosis. This is irreversible. This is gangrene. Peritonitis will follow if not treated. Requires immediate laparotomy and bowel resection. This grade carries the highest mortality. Now let's talk about the management. The ESVS diagnostic flowchart divides patients into 3 risk levels based on clinical suspicion. First, no suspicion. That is, wait and watch. Moderate suspicion, when you have diarrhea, bloody stool, early bowel emptying, elevated lactate, high vasopressor requirements, positive fluid balance, high post-op potassium, low post-op hemoglobin, prolonged surgery, and this will give you moderate suspicion, and you will need flexible sigmoidoscopy. Once the flexible sigmoidoscopy is done, If no sign of ischemia, you still wait and watch. If mild ischemia, then treat conservatively with frequent clinical reassessment, monitor intra-abdominal pressure, repeat sigmoidoscopy, additional imaging as needed. If deterioration occurs, then you will consider laparotomy. Then it comes high suspicion. This will be if sepsis is there, severe abdominal pain, there is organ dysfunction, or there is already abdominal compartment syndrome. You go for immediate laparotomy. Do not delay for sigmoidoscopic confirmation. Okay, so now let's do the key summary of this. Routine sigmoidoscopy is not recommended after rupture AAA repair. Selective use only. Sigmoidoscopy is accurate to rule out colonic ischemia, but less specific for transmural. This is clinically relevant disease. Incidence in rupture AAA is 10%, and overall from meta-analysis higher after open repair than EVAR. Mortality when it occurs, around 4% of all ruptured AAA patients die of its consequences. With routine sigmoidoscopy, incidence appears 14 to 32%, but much of this is grade 1 and 2, and these are treated conservatively. In elective AAA, EVAR is 0.3% and in open repair is 2%, and both carry 43% mortality when it develops. So you can see in rupture it was around 4%, and in routine elective open repair is around 2%. However, when it develops, the mortality is 43%. Now let's talk about another complication of aneurysm repair, that's aortoenteric fistula. We will talk about this in the vascular graft and endograft infection. However, let's touch it briefly here so that we have spoken about most of the complications. Secondary graft enteric fistula, that is GEF, occurs in 0.3 to 4.3% of cases, 2 to 4 times more common after open repair than EVAR. Combined morbidity and mortality is 20 to 75%. Any patient with an aortic prosthesis and gastrointestinal bleeding must be assessed for graft enteric fistula until proven otherwise. How do you diagnose? Stepwise diagnosis. First, you go for CT angiogram. That's a class 1 recommendation, and this is the primary modality. If inconclusive, you can add 18 FDG PET CT or white blood scintigraphy. That's another class 1 recommendation. And then confirm microbiological agent. That's blood culture. That's mandatory and is part of the MAGIC criteria. And this is the part of the MAGIC criteria and guide diagnosis. Candida involvement in 31% of graft enteric fistula cases. Antifungal therapy must be considered until fungal infection is excluded. Now let's talk about the stepwise management. If the patient is bleeding, staged endovascular aneurysm repair as a bridge to open surgery first. Definitive treatment, complete graft explantation is first line, followed by in situ reconstruction with biological material, deep vein cryopreserved allograft or genopericardial graft. Extra-anatomical reconstruction is an alternative in frail patients or extensive infection. Enteric defect must be managed by gastrointestinal surgeon. Omental interposition and in situ reconstruction are preferred over simple fistula closure. Antibiotics minimum 6 weeks, potentially lifelong. Rifampicin at discharge independently reduces mortality. Reinfection only 7% with lifelong culture-directed antibiotics. For high surgical risk patients, conservative management with partial graft removal or palliative antibiotics, but reinfection rate is 39 to 45%, especially if candida or graft enteric fistula is present. So the key summary is graft enteric fistula 0.3 to 4.3%, mortality 20 to 75%, 2 to 4 times more common after open repair, GI bleed plus aortic prosthesis, graft enteric fistula until proven otherwise. Diagnosis is CT angio, then PET-CT or WBC scan. Magic criteria for microbiology exclude candida, bleeding, EVAR, bridge. If active bleeding, then EVAR to bridge first. Definitive full explantation plus biological in situ reconstruction. GI surgeon for enteric repair. Lifelong antibiotics. Rifampicin reduces mortality. Reinfection 7% with targeted therapy. Now let's talk about the EVAR follow-up. All patient CT angio within 30 days, which then stratifies into 3 groups. So once you've done the 30 days CT for all patients undergoing EVAR, you have 3 groups by stratification of the risk. One will be low risk, who will have no endoleak, anatomy within IFU, seal more or equals 10 mm, neck less or equals to 30 mm, angulation less than 60 degree, iliac diameter less than 20 mm. Around 2/3 of patients will be low risk, and that means all in IFU. And the next imaging you can do at 5 years only, and that's as per the new ESVS guideline recommendation. Second group will be high risk, such as type 2 endoleak, seal is less than 10 mm, outside IFU or high risk anatomy, annual CTA or duplex ultrasound, crossover to low risk if sac shrinks more than 10 millimeters. I say the high risk again. So the second will be high risk group, which will be including type 2 endoleak, seal less than 10 millimeter, and anything outside IFU or high risk anatomy. Annual CT angio or duplex ultrasound will be recommended. This can cross over to low risk if sac shrinks more than 10 millimeter. Now, another final group is called EVAR failure. That means type 1 or type 3 endoleak, or the sac growth is more than 10 millimeter. And this also include seal degradation. You need urgent reintervention. Regardless of group, long-term follow-up is recommended for all EVAR patients. Now, if you have an occult endoleak, how would you investigate? For occult endoleak or sac growth without visible endoleak, step up from CT angio or duplex ultrasound to contrast enhanced ultrasound. PET or white cell scan, balloon occlusion angiography, reline or conversion to open surgery if still persisting, and no reason is found. This algorithm does not apply to complex EVAR, chimney grafts, or new devices. So, 30-day CT angio for all patients, low risk 5-year CTA, high risk annual CT or duplex ultrasound. EVAR failure is reintervention. All patients lifelong follow-up, occult, endolic, first CTA, duplex ultrasound, then contrast enhanced ultrasound, and if still no cause found, PET or WBC scan, followed by angiography, and then open repair if needed. Now let's talk about the complex abdominal aortic aneurysm. Complex AAAs involve the renovisceral segment and represent 15 to 20% of all AAAs. The classification runs from short neck infrarenal is neck 4 to 10 mm, juxtarenal is neck less than 4 mm but not involving renal, pararenal is involving one renal, the paravisceral is renal plus SMA, type 4 is renal, SMA and celiac. That is the entire abdominal aorta. Okay, repair threshold is the same, motor equals 55 for men and motor equals 50 for women as per the ESVS guideline. In practice, most series treat the around 60 millimeters. Let's talk about open surgical repair. Clamp level determines approach. Suprarenal clamping carries no significant difference in mortality or renal dysfunction compared with infrarenal. Supraceliac clamping significantly worsens outcomes. So the mortality is 8% versus 2.8%, renal dysfunction 12% versus 6%, and unplanned reoperation is 24% versus 10%. Avoid it if suprarenal clamping is feasible. That means avoid supraceliac if you can do suprarenal clamping. As you can see, it significantly lowers the complications. Open surgical repair benchmarks 30-day mortality 4.1% and postoperative renal dysfunction is 14%. Permanent dialysis 3%. So this is the open surgical repair, and you can see the mortality is gone up to 4.1% with open repair. Now renal protection, when suprarenal clamp time exceeds 25 minutes, use cold renal perfusion with 4-degree Ringer's via Pruitt catheter. In an RCT, renal dysfunction was 21% with cold perfusion versus 63% with warm blood. So you can see that increased by 3 times. A dramatic difference. No pharmacological agent such as mannitol, phenol-dopam, acetylcysteine has convincingly demonstrated benefit. Now let's talk about fenestrated and branched EVAR. Fenestrated or branched EVAR is the treatment of choice in most high-volume centers. Custom-made devices are gold standard. Fenestrations suit close aortic wall contact, juxta or pararenal, while branches suit greater distance as in type 4 thoracoabdominal aortic aneurysm. Minimum seal zone is 20 millimeters. The key adjuncts: image fusion reduces contrast by 79 mils, fluoroscopy time by 14 minutes, and procedure time by 52 minutes. On-table cone beam CT detects positive findings in 28% and prompts intraoperative intervention in 18%. Fever or BEVAR outcomes: technical success 96%, type 1 endolic 7.6%, type 3 2.5%, temporary renal injury 13.2%, permanent kidney injury 0.7%. Spinal cord ischemia is 2%. Reintervention rate 15.7%. So just remember, fever or BEVAR, the reintervention is 15%, spinal cord ischemia only 2%, and again type 1 endolic around 7%, and technical success rate is 96%. At 5 years, in GENITH FEVAR trial, 30-day mortality 1.5%, freedom from aneurysm-related mortality 97%, but freedom from secondary intervention only 64%. For the fenestrated and branched aortic research consortium, secondary intervention at 1 year 18%, at 5 years 41%. However, it's mostly percutaneous and minor. So you can see that the secondary intervention rate is higher at 5 years. Now, fever or BEVAR specific endolic types: type 1C is distal bridging stent leak in the target vessel, type 3C is the main body attachment leak, and type 3D is the bridging stent fabric tear or fracture. Renal targets are more prone than visceral, and this is 6% versus 2%. Now let's talk about FEVAR or BEVAR versus open repair. There's no RCT that exists. All data are from observational with selection bias. Meta-analysis of over 7,000 patients, perioperative death non-significantly lower with FEVAR, overall follow-up mortality non-significantly higher with FEVAR, reintervention rate significantly higher with FEVAR. If we look at UK COMPASS study, 999, that is 999, that is 999 juxtarenal patients, high-risk patients with neck under 5 mm, open surgical repair mortality was 10.9% versus FEVAR 1.7%, and that's favor FEVAR. So where is 10 versus 1.7? So it's a significantly lower in mortality. Standard risk patients with neck 5 to 9 mm, FEVAR had lower 30-day mortality but worse 3-year overall survival. That is 21% versus 7.5% for open repair. Aneurysm-related death, there was no difference. So reintervention at 3 years were 27% in FEVAR versus 17.8% in open repair. Now, open repair may offer better long-term survival in patients with suitable anatomy. FEVAR is preferred in high-risk or anatomically complex cases. Centralization is mandated, and minimum 20 combined open and FEVAR or BEVAR cases per year per unit needed to be done. Now let's talk about the parallel grafts and hybrid repair. The parallel grafts such as chimney or snorkel are not recommended electively, and these are reserved for emergency or bailout, limited to 2 chimneys maximum. Chimney occlusion risk increases by hazard ratio of 1.8 for each additional chimney. Hybrid repair combines visceral bypass with standard EVAR, and this avoids aortic clumping but carries both early open surgical repair risk and late EVAR risk, and this is not recommended as a first line. Ruptured complex AAA open surgical repair 30-day mortality 32% and approaching to 50% for type 4. Endovascular options, off-the-shelf branched device, physician-modified endografts, in situ laser fenestration, parallel grafts, all justified in the acute setting. Individualized approach based on fitness, anatomy, and preferences. Let's talk about spinal cord ischemia. Spinal cord ischemia is rare after juxtarenal repair, but more relevant for type 4 thoracoabdominal repair. And extensive endovascular coverage. Endovascular juxtarenal repair carries significantly higher risk versus open repair. Mitigation by staging mean arterial pressure above 80 millimeter mercury, hemoglobin above 10 gram per deciliter, internal iliac artery preservation, neuromonitoring. Routine prophylactic CSF drainage is not recommended, but rescue drainage at symptom onset is preferred. So remember, to mitigate the risk of spinal cord ischemia, you can stage the procedure. MAP needs to be targeted above 80 millimeter mercury, that's the mean arterial pressure, and then hemoglobin needs to be above 10 gram per deciliter. And if you can preserve internal iliac, that should be recommended. Neuromonitoring is also recommended. Okay, now let's talk about the follow-up after FEVAR or BVAR. Complex AAA means renovisceral involvement, short neck 4 to 10 millimeter, juxtarenal less than 4 millimeter, pararenal 1 renal artery involved, paravisceral renal plus SMA involved, type 4 renal SMA and celiac involved. No high-level evidence exists for surveillance after complex repair, but because FEVAR or BVAR is an evolving technique, robust follow-up is mandatory. CT angiogram at 30 days and 1 year for all patients. After 1 year, duplex ultrasound is an acceptable alternative in selective patients. Assess 3 things: sac size, endoleak, and target vessel patency. Target vessel obstruction needs prompt catheter-based revascularization. A kidney is considered permanently damaged after 6 to 12 hours of warm ischemia. Dual antiplatelet therapy post FEVAR or BVAR for bridging stent patency may be considered, but evidence is insufficient for a firm recommendation. Let's now summarize. The complex AAA, 15 to 20% of AAAs repair at more than 55 millimeter. So repair at more or equals 55 millimeter in men, more or equals 50 millimeter in women. Avoid supraciliac clumping as the mortality goes up to 8% and the renal dysfunction goes up to 12%. Cold renal perfusion if clamp time is more than 25 minutes. Fever technical success rate is 96%, reintervention is 15%, and at midterm and 41% at 5 years. Image fusion saves 79 ml contrast, 14-minute fluoroscopy, and 52-minute procedure time. So image fusion is really helpful. The UK Compass fever worse 3-year survival in standard risk 21% versus 7.5% in open surgical repair. Parallel grafts only for emergency or bailout, and if it's used, it needs to be less or equals 2 chimneys. Ruptured complex open surgical repair 30 to 50% versus endovascular repair 24% 30-day mortality, which is almost half. Spinal cord ischemia, no routine CSF drainage, rescue only. Post-fever CT angiogram 30 days plus 1 year, then individualized dual antiplatelet up to 6 months is also recommended. Now let's move on to inflammatory AAAs. Start with definition. Inflammatory AAA, first described by Walker in 1972, which represents 5 to 10% of all AAAs. Patients are 5 to 10 years younger than those with degenerative AAA with a striking male predominance. Male-female ratio is 60 to 30 is to 1, which means 60 to 30 times higher in male, and 85 to 90% are heavy smokers. If we talk about the pathophysiology, 3 defining features are there: marked wall thickening, shiny white perianeurysmal retroperitoneal fibrosis, and dense adhesions to adjacent structure. Intraoperatively, they appear white and shiny. IgG4, that is immunoglobulin G4 related inflammatory AAAs, constitute approximately 50% of all inflammatory AAAs. These carry a risk of systemic IgG4 disease in other organs but rupture less frequently. Diagnosis is the classic clinical triad of chronic pain in 50 to 80%, weight loss in 20 to 50%, and elevated CRP, ESR, and white cell count in 60 to 90%. Urethral obstruction with hydronephrosis occurs in 10 to 50%, and chronic renal dysfunction in 20%. CT angiography is the imaging of choice and identifying the mental sign, that is the thickened wall from fibrosis and inflammatory cells sparing the posterior wall. Adjacent structures involved include duodenum and sigmoid colon in 60%, urethral obstruction in 20 to 40%, and left renal or caval vein in 18 to 21%. Do not include periaortic edema or inflammation when measuring diameter. This risks oversizing and triggering unnecessary surgery. 18 FDG PET CT scan detects and monitors periaortic inflammation. Medical management recommendation is all symptomatic patients should be considered for corticosteroids as first line, 30 to 80 milligrams per day, prednisolone equivalent for induction, reducing to less than 5 to 10 milligrams per day at 1 year. Steroid-sparing agents such as azathioprine, cyclophosphamide, methotrexate for refractory cases. Rituximab is effective in IgG4-related disease. Tamoxifen 20 mg twice daily showed resolution in 15 of 19 patients in a prospective study. ESR and CRP alone are unreliable for monitoring. Use PET-CT to guide steroid decision. Let's talk about surgical management. Rupture risk is less than 5%, the same more or equals 55 mm threshold as degenerative AAA applies. Repair at more or equals 55 mm with EVAR preferred over open surgical repair if anatomy is suitable. 30-day mortality is 2.4% versus open surgical mortality is 6 to 11%. Open surgical repair is technically demanding. Suprarenal clamping is required in up to 40%. Preoperative urethral stents are required in 90%. Avoid extensive adhesiolysis. Leave the duodenum attached to the pill. After open surgical repair, fibrosis regress in up to 86% and hydronephrosis in up to 80%, but this can take years. Post-EVAR, fibrosis resolves more slowly and hydronephrosis may persist or worsen, requiring double J stenting. Lifelong surveillance and immunosuppression are warranted after repair. Fibrosis and hydronephrosis can persist or progress despite open surgical repair or endovascular aneurysm repair. So, to summarize, 5 to 10% of AAAs are inflammatory AAAs, mainly young patients, male 6 to 30 is to female is 1, 85 to 90% smokers, 3 hallmarks, wall thickening, retroperitoneal fibrosis, and then adhesions. IgG4 related is around 50%. This gives systemic disease, lower rupture rate. Triad is pain, weight loss, and raised inflammatory markers. Mental sign on CTA do not include edema during measurement of the diameter. Rupture is less than 5%, same as more or equals 55 mm treatment threshold as degenerative AAA. Steroids 30 to 80 mg per day reduced to less than 10 mg at 1 year. Open surgical repair mortality 6 to 11%, suprarenal clamp 40%, urethral stents in 90%. EVAR preferred, 30-day mortality is 2.4%. Lifelong surveillance plus immunosuppression after repair is required. Now let's quickly talk about infected aneurysm. True mycotic aneurysm, classically from septic emboli to the vasa vasorum, often in infective endocarditis, commonly due to streptococci or staphylococci. From microbial arthritis with aneurysm formation where blood-borne bacteria need a diseased intima, producing suppuration, perforation, and pseudoaneurysm formation. Classically involving the aorta and often with organisms such as Salmonella, E. coli, Staph, or Klebsiella. Infected aneurysm is biologically and surgically different from degenerative aneurysms and requires suspicion, microbiology, prolonged antibiotics, and definitive exclusion or reconstruction in an infection-aware strategy. Now let's talk about iliac artery aneurysm. An iliac artery aneurysm is defined as dilatation more than 1.5 times normal diameter. In practical terms, common iliac artery aneurysm is more or equals to 18 mm in men and more or equals 15 mm in women. Internal iliac artery aneurysms are more or equals to 8 mm. Iliac artery aneurysms commonly coexist with abdominal aortic aneurysm as aortoiliac aneurysms. Isolated aneurysms means no concomitant infrarenal aortic aneurysms. Overall frequency up to 7% of all aortoiliac aneurysms. Of isolated iliac artery aneurysms, 12 to 48% are bilateral. Demographics showed 90% male and diagnosed at age 70 years of age. The most widely used anatomical classification is the Roberts classification. Type 1 is isolated common iliac aneurysm. Type 2 is common iliac plus internal iliac aneurysm. Type 3 is internal iliac isolated aneurysm, and type 4 is external iliac. So to repeat again, type 1 is common iliac isolated, type 3 will be internal iliac, type 4 will be external iliac, but type 2 will be common and internal. External iliac aneurysms are rare, that means the type 4 will be rare. Type 4 is the external, type 3 is the internal. Type 1 is the common, type 2 is the common plus internal. Okay, let's go to the surveillance and indications for repair. Most isolated internal iliac aneurysms are asymptomatic. Symptoms arises from local compression of the ureter, sacral plexus or iliac vein. Rupture has been reported in 4.3% and symptoms in 18% of isolated iliac artery aneurysms. Growth rate is approximately 1 to 4 mm per year, depending on size, similar to AAA. So more specifically, common iliac artery aneurysms 20 to 24.9 mm is 0.2 mm per year growth, 25 to 29.9 mm 0.3 mm per year growth, and more than 3 is 1.3 mm per year growth. Rupture risk below 4 mm is very low. A meta-analysis found 2 ruptures below 40 mm of 983 iliac artery aneurysm. Most ruptured iliac artery aneurysm in the literature are larger than 5 mm. Based on this, the 2024 ESVS guideline raised the intervention threshold to more or equals 40 mm, applicable to common iliac, internal iliac, and external iliac aneurysm. So remember this: 4 centimeter more or equals to 4 centimeter or more equals 40 mm is the treatment threshold for any iliac aneurysms. Now the surveillance is 2 to 2.4 centimeter, or if we say 20 to 24 mm every 3 yearly, 25 to 29 every 2 yearly, more or equals to 30 annually, and preferred modality is ultrasound with CT angio reserved for large aneurysms or poor ultrasound visibility. So just to say the surveillance, 20 to 24, 3 yearly, 25 to 29, 2 yearly, and more than 30 is annually. Now, repair threshold, as we said, is more or equals to 40 mm regardless of gender, though patient body size and fitness should inform the individual decision. Surgical treatment, open surgical repair, general anesthesia, retroperitoneal or transabdominal access. The deep pelvic location make open surgical repair of iliac artery aneurysm technically challenging, higher risk of iatrogenic injury to veins, ureter, and sacral nerves. 30-day mortality for open repair is 8.2% versus 2.8% for endovascular repair. Endovascular repair, now the preferred approach. Perioperative mortality for endovascular iliac artery aneurysm repair was 0.7% only, and this was shown in a meta-analysis. Local anesthesia is a significant advantage in ruptured isolated iliac aneurysms. Conversion to open is uncommon. Iliac branch device (IVDs) have transformed the field, allow internal iliac artery preservation even in isolated iliac artery aneurysm. Meta-analysis of IBDs: 22% in isolated common iliac aneurysms, 8% in internal iliac aneurysms. High technical success, low pelvic ischemia, 0.4% 30-day mortality. IBD reintervention and occlusion rates around 20% and 15% at 5 years. Limiting anatomical factor and aneurysmal internal iliac artery itself. Choice of technique based on individual patient and lesion characteristics, anatomy, fitness, patient preferences. Both techniques are complementary. Now let's talk about the pelvic circulation, and always remember at least one internal iliac artery must be preserved wherever possible. Bilateral internal artery occlusions significantly increase the risk of buttock claudication, colonic ischemia, pelvic necrosis, erectile dysfunction, and spinal cord ischemia. Internal iliac artery contributes to the spinal cord collateral network. Buttock claudication occurs in up to 28% when internal iliac artery perfusion is not preserved. Contemporary IBD meta-analyses report rates of 11 to 14%, much improved with preservation techniques. When embolization of the internal iliac artery is unavoidable, embolize proximally in the main stem to preserve communication between anterior and posterior divisions. Distal embolizations significantly increase buttock claudication risk. In bilateral internal iliac artery involvement, stage the treatment to allow collaterals development. But be aware that staging carries its own rupture risk. What about follow-up? There is no robust data specific to iliac artery aneurysm. Follow standard post-EVAR surveillance protocol. Type 1 and Type 3 endoleaks reported and require reintervention. Type 2 endoleaks most common, but no reports of rupture in one meta-analysis. Okay, now we will go through a rapid-fire SBA practice for the exam. Let's start. A 76-year-old man under AAA surveillance shows a growth from 4 and 5.1 centimeter in 6 months. What is the next step? So you can see from 4 to 5.1, that is 1.1, which is 11 millimeter in 6 months, and that mandates urgent reassessment with CT angio for operative planning rather than continued surveillance. A 72-year-old man has a 4.8 centimeter AAA, which increases from 4.2 centimeter in 6 months. What is the next step? Again, urgent CTA if you see from 4.2 to 4.8, which is 6 millimeter in 6 months. If you think more than 5 millimeter in 6 months, that is more than 10 millimeter in 1 year. Okay. A 72-year-old patient presented with ruptured AAA. Which statement is incorrect in initial management? Rapid infusion of 2-liter crystalloid, you know that this needs to be permissive hypotension, so that's definitely incorrect. A 74-year-old man undergo EVAR and later develops sac expansion without visible endoleak or imaging. What type of this? This is type 5 endoleak or endotension, as we said. Sac expansion without visible endoleak is type 5 endoleak. 70-year-old patient post-EVAR has suspected endoleak. What is the gold standard investigation? CT angiogram. There is no doubt about it. A 75-year-old patient develops a type 1A endoleak with proximal graft migration after EVAR. What is the next step? You all know proximal cuff extension. A 73-year-old has a mycotic AAA. What is the most appropriate initial management? Intravenous antibiotics with culture. Early management include targeted antibiotics before definitive repair. So keep in mind, it says initial management, did not say definitive management. So this sort of things, as I mentioned earlier, in the written exam are really crucial. What is the most common organism in mycotic aneurysm? As we earlier said, for infective aneurysm, Staphylococcus aureus, and the other ones are Streptococcus. So Staphylococcus are the most frequent pathogens in mycotic aneurysms. What is the most common organism in prosthetic graft infection? A 79-year-old develops hematemesis after previous AAA repair, and CT is inconclusive. What is the next step? So there it is a delayed complication of AAA repair as aortoenteric fistula, and again the CT, if is inconclusive, you go for OGD. A 70-year-old patient presented with upper GI bleeding after EVAR. What is the next investigation? Upper GI endoscopy. First line investigation is endoscopy to identify bleeding source. A 77-year-old patient develops intra-abdominal pressure of 30 mm after ruptured AAA. What is the next step? You remember, more than 30 mm, there is no question, we go for decompressive laparotomy. And even if it was more than 20 mm, with organ dysfunction, we still go for decompressive lap. A 74-year-old patient who has ruptured AAA with bilateral iliac aneurysm. What is the key surgical principle? Maintain at least one internal iliac artery, as we discussed already. A 65-year-old man has a 5.5 centimeter AAA and a 3.5 centimeter popliteal aneurysm. Which should be treated first? If the 3.5 centimeter AAA is not symptomatic, you treat the 5.5 centimeter AAA because that's life-threatening if it ruptures. Whereas if the 3.5 centimeter popliteal aneurysm become symptomatic, such as distal embolization, that become limb-threatening. A 76-year-old patient with metastatic cancer is found to have 13 centimeter AAA suitable for EVAR. What is the best management? You go for conservative management or palliation. Limited life expectancy favors non-intervention, and as per European Society of Vascular Surgery guideline, the limited life expectancy was meant 2 to 3 years. A 74-year-old patient with inflammatory AAA and enterotomy during repair. So a 70-year-old patient post-AAA repair develops rising lactate and acidosis. What is the next step? We said the next step will be sigmoidoscopy, or if you have no sigmoidoscopy option available, if there's colonoscopy, you can choose that one as well, because as this could be the colonic ischemia grade 2. So you can confirm this by either sigmoidoscopy or colonoscopy, even though the ESVS guideline clearly mentioned sigmoidoscopy. A 75-year-old patient with suspected graft infection shows focal uptake on PET scan. A 72-year-old patient has an expanding sac after EVAR, but imaging is inconclusive. What is the next step? You go for CT angiogram. Repeat CTA is required for further evaluation of endoleak, and you know what is next. A 69-year-old patient has juxtarenal AAA with unsuitable neck for EVAR. What is the preferred treatment? You go for open repair because the patient is young, and if he is fit, you go for open repair. A 73-year-old patient develops impotence after open AAA repair. What structure was injured? We know that hypogastric plexus and injury to autonomic plexus causes erectile dysfunction and retrograde ejaculation. A 75-year-old patient with AAA repair is hypotensive but conscious. What is the hemodynamic strategy? You go for permissive hypotension. A 71-year-old patient develops lymphatic leak after AAA repair with high output. What is the initial management? Drainage and nutritional support. Conservative management includes drainage and dietary modification before any further intervention. A 77-year-old patient with AAA develops sac expansion and stent fracture on X-ray. What is the next step? You have to do CT angiogram for further planning of management and intervention. A 70-year-old patient presents with suspected aortoenteric fistula and unstable condition. What is the first diagnostic step? So remember, it says first diagnostic step. So you have to confirm the diagnosis by definitive investigation, and that's OGD. Endoscopy is essential when CT is inconclusive. So here patient is unstable, so you have to go for OGD due to GI bleed. A 68-year-old patient with AAA has heavy calcified aorta, making endovascular access difficult. What is preferred? Open repair is preferred because 68-year-old patient is here, younger patient, and there is access is difficult anyway as well. A 75-year-old develop abdominal compartment syndrome post AAA repair. What would happen physiologically? So if the abdominal compartment syndrome develops, that means intra-abdominal pressure is very high, you will have decreased venous return. Raised intra-abdominal pressure reduces venous return, and that also precipitate organ dysfunction by organ hypoperfusion. A 74-year-old patient has a AAA and a liver metastasis. What is the best management? This would be conservative. Again, with the liver metastasis, this is advanced malignancy. There would be limited prognosis with limited life expectancy, and that shifts the management toward palliation rather than repair. Thank you very much. We are at the end of this topic. Thanks for listening to the Proximal Control Vascular Surgery Exam Prep. If you have found this useful, stay tuned, because in the next episode we will build more on abdominal aortic aneurysms based on the ESVS and NICE guidelines. We will also discuss saccular aneurysm, PAU, IMH. These are most important topics for written as well as clinical and oral exam. As always, with your support, we will grow together. Keep listening to Proximal Control, because in vascular surgery, control is everything.